week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP EMED and for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
The opportunity to introduce our next presenter, and this is Abigail Wolff. She is one of the PGY2 Emergency Medicine Pharmacy residents at Hackensack University Medical Center, and she will be presenting her journal article, Intravenous tenecteplase, compared with alteplase for acute ischemic stroke in Canada. So Abigail, you can share your screen, and whenever you are ready, take it away.
Thank you for the introduction, Kyle. As mentioned, my name is Abigail, and I will be presenting on the ACT trial today. The learning objectives are to describe the role of thrombolytic agents in the management of acute ischemic stroke and review data from the ACT trial on tenecteplase for stroke. To begin with some background information, alteplase and tenecteplase are fibrin-specific tissue plasminogen activator products, and each of these agents works by binding to fibrin and converting the entrapped plasminogen to plasmin. Of note, tenecteplase does have about a 15-fold higher fibrin specificity compared to alteplase. Tenecteplase also has resistance to plasminogen activator inhibitor 1, as well as a longer half-life. The initial half-life for tenecteplase is about 20 to 24 minutes, whereas with alteplase, the initial half-life is less than 5 minutes. On the slide, I've also included the dosing for alteplase and tenecteplase specifically for acute ischemic stroke. There are other dosing regimens if these agents were being used for their other indications, such as MI or PE. For alteplase, the consensus dosing is 0.9 milligrams per kilogram with a max dose of 90 milligrams. And this is given as 10% of the total dose as an IV bolus over 1 minute, followed by the remainder of the dose as an IV infusion over 60 minutes. For tenecteplase, the consensus dosing for stroke is 0.25 milligrams per kilogram with a max dose of 25 milligrams, given as an IV bolus over 5 seconds. And it really is that longer half-life that tenecteplase has compared to alteplase, which allows it to be administered as an IV bolus compared to the infusion. At this time, alteplase is FDA approved for acute ischemic stroke, while tenecteplase is used off-label, but we will be focusing on tenecteplase today as it is part of the ACT trial, and its use for stroke really has been increasing in the recent years. When looking at alteplase and tenecteplase for stroke, there are some proposed advantages of tenecteplase to consider. Relating to its simpler dosing and administration, it may be easier to calculate the doses of tenecteplase. While it is still a weight-based dose, it is not broken up into a bolus and then infusion as alteplase is. And also because of this, tenecteplase does not require an infusion pump to be administered as it's a bolus, which can definitely be an advantage in the emergency department where infusion pumps can be challenging to come by. And also, since it's not an infusion, there is no pump tubing that will need to be flushed following its administration. And with alteplase, this is a major consideration and always a counseling point that the line must be flushed afterwards to ensure the complete dose is given to the patient. Another proposed advantage is that since tenecteplase has a higher fibrin specificity, in theory, it would have a lower bleeding risk. And then lastly, cost can be an advantage as a 50 milligram vial of tenecteplase is less expensive than a 100 milligram vial of alteplase. However, any cost differences really will be institution specific. The 2019 American Heart Association and American Stroke Association guidelines for the early management of patients with acute ischemic stroke do acknowledge both alteplase and tenecteplase, but their recommendations for each of these agents differs. For alteplase, the guidelines recommend this agent in selected patients who can be treated within 4.5 hours of their last known well, and state it can also be beneficial in patients outside of this window based on specific MRI imaging. And then on the other hand, for tenecteplase, the guidelines state that it may be reasonable to choose tenecteplase in patients who are also eligible for thrombectomy, and that a dose of tenecteplase at 0.4 milligrams per kilogram could be considered as an alternative in patients with minor neurologic impairment and no major intracranial occlusion. Notably, these guidelines are from 2019, and more literature has emerged since they were last updated. With this newer literature, tenecteplase has been used by institutions really following the same recommendations as the guidelines state for alteplase. And before diving into the literature that is available on tenecteplase for stroke, there are two scales that I wanted to highlight as they're referenced in many of these key trials. The first is the National Institutes of Health Stroke Scale, which is the gold standard for rating stroke severity. There are several different components that are taken into consideration when calculating the score, but ultimately, the higher the score, the more severe the stroke. And then the second scale is the Modified Rankin Scale, which is a categorical scale for functional neurologic outcome and ranges from 0, meaning no neurologic symptoms, to 6, meaning death. And a very common primary outcome for our stroke studies is an MRS score of 0 to 1 at a follow-up period. So this would mean patients either had no neurologic symptoms or no significant disability despite any symptoms they may have. Now to get into the supporting literature, on this slide I've highlighted two studies that were published prior to the 2019 guideline update. First is the NORTEST 1, which is a phase 3 randomized superiority trial that compared tenecteplase at a dose of 0.4 milligrams per kilogram with our standard dose of alteplase. This trial enrolled over 1,000 patients, and the median NIHSS score was 4, with 20% of patients having a large vessel occlusion. The primary outcome was the MRS score of 0 to 1 at 90 days, and there were no significant differences between the two groups. And there were also no significant differences between those who received alteplase and tenecteplase with respect to symptomatic intracranial hemorrhage. Therefore, the study concluded that there does not appear to be any difference in efficacy or safety between tenecteplase and alteplase. But notably, with the median NIHSS of 4, this trial really highlighted patients who had minor neurologic deficit. The second trial was the Extend IAT&K trial, published in 2018. And this was a phase 2 randomized non-inferiority trial that compared tenecteplase at a lower dose of 0.25 milligrams per kilogram with alteplase before thrombectomy. This trial enrolled 202 patients, and the median NIHSS was 17, with 100% of patients having a large vessel occlusion. The primary outcome was substantial reperfusion at initial angiographic assessment, and this occurred in 22% of patients who received tenecteplase and 10% of patients who received alteplase. There were then no significant differences with respect to intracranial hemorrhage. So the study concluded that tenecteplase was non-inferior to alteplase in patients prior to a thrombectomy. Now moving on to the literature that has been published since the 2019 guidelines. First is Extend IAT&K Part 2, which was a randomized clinical trial that compared a lower dose of tenecteplase, 0.25 milligrams per kilogram, with the higher dose of 0.4 milligrams per kilogram before thrombectomy. There were 300 patients enrolled, and the median NIHSS was 16 to 17, again with all patients having a large vessel occlusion. And this study found no significant differences with respect to the primary outcome or symptomatic intracranial hemorrhage, and therefore concluded that there doesn't appear to be any advantage to utilizing a higher dose of tenecteplase in this patient population. And then lastly, NORTEST 2 Part A was a phase 3 randomized non-inferiority trial published just earlier this year. and it compared the higher dose of tenecteplase, 0.4 milligrams per kilogram, with alteplase. It enrolled over 200 patients, and notably, the median NIHSS was 11 to 11.5, which was a group of patients that we hadn't seen highlighted as much in previous studies, as the previous studies really highlighted mild stroke and then patients undergoing thrombectomy. For the primary outcome of MRS score of 0 to 1 at 90 days, this was achieved by 32% of the tenecteplase group and 51% of alteplase. And then this study is most notable for its safety outcomes, where symptomatic intracranial hemorrhage occurred in 6% of the tenecteplase group and 1% of the alteplase group. And ultimately, this study was terminated early due to high rates of symptomatic intracranial hemorrhage with tenecteplase. So this study did not favor tenecteplase in acute ischemic stroke and concluded that the dose of 0.4 milligrams per kilogram might be too high in this patient population, and maybe a dose of 0.25 milligrams per kilogram would be more appropriate for all patients eligible for thrombolysis who are not necessarily undergoing thrombectomy. But we really didn't have data to support that until the ACT trial was published just at the end of June 2022. So the ACT trial was the intravenous tenecteplase compared with alteplase for acute ischemic stroke in Canada. It was a multi-center, open-label, randomized controlled non-inferiority trial conducted at 22 primary and comprehensive stroke centers across Canada from December 2019 to January 2022. And the objective was to determine if tenecteplase is non-inferior to alteplase in all patients presenting early after acute ischemic stroke who meet criteria for IV thrombolysis. The inclusion and exclusion criteria for the trial are essentially the inclusion and exclusion criteria that we utilize when assessing if a patient is a candidate for IV thrombolysis. For the intervention, patients were randomly assigned in a one-to-one fashion to receive either tenecteplase or alteplase with the following doses. The dose of tenecteplase was 0.25 milligrams per kilogram with a max dose of 25 milligrams given as an IV bolus. And then for alteplase, it was the standard dose of 0.9 milligrams per kilogram administered first as an IV bolus with 10% of the total dose, followed by the remaining dose as an infusion over 1 hour. The primary outcome was the proportion of patients with a score of 0 to 1 on the MRS at 90 days up to 120 days. And secondary outcomes included the MRS score of 0 to 2 at this follow-up period, the actual MRS score, return to baseline function, the Euroqual visual analog scale, door to needle time, proportion of patients given endovascular therapy, and length of hospital stay. And these outcomes at the 90 to 120-day follow-up period were assessed by individuals conducting phone interviews who were blinded to which treatment the patients received. For safety outcomes, symptomatic intracerebral hemorrhage, angioedema, and extracranial bleeding requiring blood transfusion were all assessed up to 24 hours after the IV thrombolytic was administered. And then 90-day all-cause mortality was assessed as well. For the statistical analysis, this was a non-inferiority trial, and the non-inferiority margin was set at 5%. Therefore, if the lower boundary of the 95% confidence interval of the primary outcome was greater than negative 5%, non-inferiority would be established. And this primary outcome was analyzed in the intention to treat population. Overall, there were 1,600 patients enrolled, with 816 randomized to tenecteplase and 784 randomized to alteplase. And ultimately, 806 patients were included in the intention to treat population for tenecteplase and 771 for alteplase. When looking at the baseline characteristics, they were very well matched between the two groups. I would like to point out that the baseline NIHSS scores were 9 and 10 for tenecteplase and alteplase respectively. which is important as that's the patient population that we hadn't had data on previously in the stroke trials. Additionally, about 25% of patients in each group had a large vessel occlusion. And then over 93% of patients received care at a comprehensive stroke center, and the door-to-needle times were about 36 to 37 minutes. For the efficacy outcomes, beginning with the primary outcome of the proportion of patients with an MRS score of 0 to 1 at 90 to 120 days, this occurred in about 37% of patients who received tenecteplase and about 35% of patients in the alteplase group. The lower boundary of the confidence interval was negative 2.6, which is greater than negative 5, and therefore non-inferiority was established. Other efficacy outcomes I'd like to point out are the actual MRS score, return to baseline function, and the EQ-VAS at the follow-up period, as there were no significant differences between the two groups. For safety outcomes, there were no significant differences between alteplase and tenecteplase with respect to mortality at 90 days, symptomatic intracerebral hemorrhage, extracranial bleeding requiring transfusion, or angioedema. And based on these results, the authors concluded that this trial provides robust empirical evidence that tenecteplase is comparable to alteplase in patients presenting with acute ischemic stroke with similar function, quality of life, and safety outcomes. And due to the ease of administration of tenecteplase, this trial provides a compelling rationale to switch the standard of care thrombolytic agent for stroke to tenecteplase at a dose of 0.25 milligrams per kilogram. For my study critique, overall, I feel that this was a very strong and well-done study. There was a large sample size included with baseline characteristics well matched between the two groups. And it also was a very pragmatic design where the inclusion and exclusion for the trial really match what we currently do in clinical practice when assessing if a patient is a candidate to receive IV thrombolysis for stroke or not. Additionally, I feel it was appropriate for this to be a non-inferiority trial. And with the small margin of 5%, we can be comfortable that with these results and non-inferiority being established, tenecteplase is not worse than alteplase for acute ischemic stroke. Also, the blinded outcome assessment was a strength to help reduce bias when the interviewer is collecting the information at 90 to 120 days to assess the MRS score and return to baseline function. I also thought the efficacy and safety outcomes were strengths. For the efficacy outcomes, the MRS score of 0 to 1 at 90 days is a common primary outcome for previous stroke studies. So I thought it was good that this was reflected in the ACCP trial as well. And the study also assessed outcomes that really matter to us as the treatment teams, as well as to the patient. When looking at the MRS score, as well as return to baseline function, this is the information that the patients want to know when thinking about getting this treatment or not. Additionally, the safety outcomes had appropriate time intervals that were looked at, really 24 hours after the administration of the thrombolytic agent is when we would expect to see any angioedema or intracranial hemorrhage or extracranial bleeding relating to the agent. So the study reflected that well. And then lastly, having the median baseline NIHSS of 9 to 10 is a strength because I've mentioned a few times, this really was a gap in literature previously. We didn't necessarily have concrete data on tenecteplase for patients who were maybe undergoing thrombectomy, maybe not undergoing thrombectomy. And now we have information on more of a moderate to moderate severe patient population who may or may not be undergoing thrombectomy afterwards. For the limitations, the majority of patients did receive care at a comprehensive stroke center, and door-to-needle times were 36 to 37 minutes, which is very fast and are very impressive times, but we don't always see that reflected in clinical practice, which may affect the patient outcomes. If the door to needle times were slower in clinical practice, I still would not expect to see any differences between alteplase or tenecteplase based on this trial, but overall the outcomes might be different for each group simultaneously. And overall, for my personal conclusions, I feel that the results of the ACT trial do fill a gap in the literature available on tenecteplase for acute ischemic stroke, and really do show that tenecteplase is a safe and effective alternative to alteplase in all patients who meet criteria for thrombolysis for stroke. Before this study was published, there were many institutions who had already switched to tenecteplase for stroke or had approved it and were in the process of switching. Some institutions may have been considering the switch but had not made a final decision yet. And maybe for others, it wasn't quite on the radar at that time. But where I really feel these results come into play is that for those institutions who have switched to tenecteplase, we now have even more robust data to support tenecteplase as an appropriate alternative agent. And then for the institutions who have not yet switched, it certainly could be a decision that's made. Tenecteplase is an appropriate alternative, but we know that it's non-inferior. It's not superior to alteplase. So institutions do not have to switch to tenecteplase for acute ischemic stroke. And then lastly, outside of a controlled trial environment, there are additional operational and safety considerations that will arise and need to be addressed, such as if there's going to be multiple thrombolytic agents on formulary for different indications and some of the medication safety issues that could arise with that. Where will the medications be stored? Who is going to be preparing them? We don't see all of these considerations reflected in a trial. And with that, I thank you all so much for your time today.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.